Thank you very much. It's my pleasure to be here today. It was all quiet today. I'm going to leave my phone over there because it's blowing up because Matthew is coming to Charleston. So they're already canceling clinics. But it's my pleasure to talk to you about cystic fibrosis today. All right, so this is a success story when we talk about cystic fibrosis, and it's always fun to start off with a slide like this to show how the median age of survival has improved over the decades. So whereas at one time it was if your child was born, that child was not likely to see their teens or their 20s, now the median age of survival is 41 years of age. And for the first time, the majority of our patients are now living into adulthood. But there's another way of looking at this, and that's the glass half empty, and we're not anywhere close to what we would consider normal survival, so we have a long ways to go. When we talk about cystic fibrosis and the complications that can occur, most of what we end up talking about are the pulmonary complications. I'm a lung physician. It's very typical that most CF docs are pulmonary docs. I'm not going to go through all of these complications, but some are more common than others. So gastrointestinal, digestive issues, hepatobiliary issues, endocrine problems, particularly with diabetes. We're always dealing with chronic sinusitis, but essentially you need to know all of internal medicine to take care of these patients. We're dealing with every organ system, multiple complications as a result of both disease and potentially treatment. Now, when we look at the reasons that our patients die, for the most part, is because of their lung disease. The majority of these patients die either because of lung disease or complications of transplant, which are typically done for pulmonary disease. And so that's why I'm going to focus the rest of my talk on the pathogenesis and the treatment of lung disease. So CF is a genetic disease. It codes for a protein that we call the cystic fibrosis transmembrane conductance regulator, which is a mouthful, so we call it CFTR. And that is important in the maintenance of the airway surface. So in this video that was put together by the Cystic Fibrosis Foundation, we're hovering over here along the surface of the airway. You see those cilia, those little hair-like projections working in concert to move that mucus across the top and help clear out the airways. These cilia are working within a fluid layer, this airway surface liquid, which is maintained by the CFTR and other molecules. And so here, these yellow-orange molecules, that's the CFTR sitting in the top of that, through which chloride is flowing. The others are sodium channels that are absorbing sodium. In the cystic fibrosis airways, what you see is that airway surface liquid is very shallow. And so those cilia can't stand up and do their thing, and the mucus becomes thick and inspissated in a ripe environment for infection to set in. And when we zoom into the airway surface here, when you look at those CFTR molecules, in this setting, they're present, but they're not working. Chloride is not flowing through, sodium is being overly absorbed, and with salt goes water, making that surface layer very shallow. These gene mutations, there are many, many gene mutations, but we simply categorize them into those that result in a reduction in the quantity of those CFTR molecules or a reduction in their function. And between those two properties, we end up with a reduction in the airway surface liquid, which impairs mucociliary clearance, and that leads to one of the complications, which is obstruction of the airway. Here's one way of looking at that. This is an airway. I know there's a button on here somewhere. Right here, and what you see is this big plug basically obstructing the airway. Another way of looking at that is looking at the CT scan, and normally we do the CT scans after a deep inspiration. But in this case, we look at it after an expiration, and the temptation is to think that these dense areas are abnormal, but that's normal. These are areas in which air is trapped and can't get out. So even in patients who seem to have normal lung function, we'll have evidence of obstruction very early on. The airways are ripe for infection. Infection is typically chronic, meaning it gets there and it doesn't go away. It persists, and we see a large number of different bacteria that infect our patients. This is looking at registry data through their ages, and so as they get older, you see a changing microbiology. So whereas the younger patients are more commonly infected with Staph aureus, Pseudomonas becomes the principal pathogen affecting our adults, and you see that MRSA is actually increasing there as well. So we see a great many different bacteria in our patients, and with infection comes inflammation. Here's a very simple demonstration of what we see. This is from a bronchoscopy, getting lavage fluid from a healthy child, and what you see is a not very cellular material, and these are all typically macrophages, and in the CF patients, lots and lots of active cells, and they're principally neutrophils. And so the inflammatory response in CF is exaggerated. So these problems work together. With infection, you get inflammation causing more worse obstruction. Those result in progressive, irreversible lung damage and eventually respiratory failure. We have a whole slew of medications that have been developed over the last 3 decades that we treat our patients, and we have guidelines that provide recommendations to our clinicians upon how they work and which ones that you might use. I'm not going to go through all of them, but we can show you where they sort of target the steps in the pathogenesis. And what you see is all of these medicines that we had developed previously are typically treating these sequelae, the consequences of CF lung disease. They're treating the downstream consequences. But if we really want to make a big difference, we want to work upstream and treat that basic defect. And so different strategies might be to replace the gene therapy. Maybe we could find some way to bypass the function of the CFTR protein, or maybe we could actually fix that defect and make it work more properly, which is what we're talking about when we get into the CFTR modulators. I simply may describe the CF mutations as occurring with a decrease in quantity or decrease in function, but we categorize these into 5 different classes of gene mutations. And so when you think about strategies of trying to treat this, you can't think one size fits all. So in our class 1 mutations, these are resulting in early stop codons, and so you end up with a truncated protein. Essentially, it's a nonsense protein. Class 2 mutations, they're making protein, but it doesn't fold and traffic and get up to the cell membrane. It gets discarded by the cell. That's what we see in the most common mutation, which is the deletion of 508. Class 3 mutations, they make the protein, it gets to where it needs to, but the gate doesn't open, so stuff can't flow through it. In class 4, the gate can open, but the conduction through that channel is impaired. So think of it like a very narrow pipe in which this is going to flow. And then class 5 mutations are more about splicing mutations, and so the efficiency of making your protein is reduced, so you end up with a reduction in quantity. And so you can look at these a little bit differently. If this is the normal situation, going from Charleston, thinking of the cell surface like the surface of our harbor, and these are buoys out in the harbor. In those class 1 and 2 mutations, you see there's virtually no protein. And then in class 3, we have protein, and same with class 4, but they're not functioning very properly. And then in these other mutations, there's a reduction in the quantity. So we have to have a very different approach to how we treat these. And so the first approved drug is Ivacaftor, and it is a potentiator of CFTR. And so when we think about how we make the diagnosis of CF with a sweat test, I just want to talk briefly about what we do with a sweat test. So when you sweat, here's your sweat gland, you stimulate the gland and you make sweat, which is isotonic. It has the same salt concentration as your blood. And it's going to work its way through up to the skin surface where it can evaporate. But your goal of a sweat gland is to get rid of heat, not get rid of salt. So as it passes through here, it reabsorbs the salt, so what gets to the cell surface or the skin surface is very dilute, it evaporates, and you lose heat. But in cystic fibrosis, the problem is that they can't reabsorb that salt because of the absence or the impaired function of the CFTR protein. And so in CF, your sweat chloride is elevated. It's saltier. So when Ivacaftor was developed, we tested it looking at its effect on sweat test. And what you see in this comparison, this is the placebo group where the sweat chloride didn't change, and those who were on Ivacaftor had a marked reduction in their sweat chloride. And that reduction actually brought them into not the normal range, but below what we typically consider to be compatible with cystic fibrosis. So that's a marked improvement. But you can't approve a drug based upon improvement in sweat. And so when you look at clinical pictures, this is looking at lung function. The placebo group had no improvement in lung function, but look at the treated group, had a marked improvement in lung function that was sustained. Our patients suffer exacerbations of their lung infections where their symptoms become worse, and you could see that those treated group had a reduction in the frequency of exacerbation compared to placebo. They had greater weight gain, they had better scores on their quality of life, so it was a major home run, and the drug was approved for patients that had the G551D mutation. Well, what about other mutations? Could we treat these patients even earlier, younger, that would prevent these complications over time? Or could we treat other mutations with these same medications? And so we began to look at those, and I'm not going to go through all the data, but the drug has now been approved to include other gating mutations that are similar to the G551D mutation. They've been approved for patients who have a category 4, class 4 mutation, the R117H with a conductance mutation. It's been approved for even younger children. We tested it in patients who have delta F508, and it was shown not to be effective in those patients. We knew that, though, because remember, it was a class 2 mutation in which there's not protein on the cell surface, so the Ivacaftor can't work there. But that becomes our major target because it is by far the most common mutation that we see in our patients. 50% of our patients are homozygous for delta F508, and another 40% have a single copy of that delta F508, so that's why we'd like to try to get that one solved. But you have to have a different strategy there, and that's where you get into correctors to try and increase the quantity of protein. What this basically does is it stabilizes part of that folding process, so you can increase the trafficking of getting more protein up to the cell surface. What we've learned about delta F508, though, is it actually has some gating abnormalities, so it might, if you can get more of it up there, you might still want to hit it with a potentiator like Ivacaftor. And a third problem is this protein is still a little wonky, so when it's up in the cell membrane, it doesn't stay there as long. So you might think about strategies of trying to increase its longevity there. So when we think about the status of targeted therapy, we have 5% of our patients have gating mutations. Another 5% have these conductance mutations. The big dog is the delta F508, so the homozygotes accounting for nearly half of our patients, and another large percentage of having heterozygotes. And I didn't spend much time talking about the stop codon mutations, those class 1 mutations, but those are a fair number of our patients. And if we're looking at one method of trying to improve the health of these patients, we look at lung function, and we now have 2 approved products. Ivacaftor as a potentiator, which is approved for those gating mutations and those conductance mutations, and Lumacaftor or Ivacaftor, or Orkambi, which is approved for patients who are homozygous. What you see in terms of the actual response is demonstrated here. And so another way of looking at this is our unrealized opportunity of who we want to get better, how we want to approach these patients and do an even greater job of treating those patients. So we want drugs that have greater benefits. We want even greater benefit on lung function, but we also want to have that systemic benefit. I've not shown you any data about the systemic effects of these drugs, but it's the gift that keeps on giving in terms of reducing complications of sinus disease, diabetes, improved nutrition. We want to treat all patients, which means we've got to get those other mutations and try to solve those issues. And we want to treat patients before they develop those consequences of disease. And so we want to be able to treat younger and younger patients who don't have bronchiectasis and chronic lung infection. So we have a lot of opportunities in the pipeline. And our different strategy can start at the very bottom, where we're trying to work on getting more protein, increase the amount of immature CFTR protein. There was always great promise for gene therapy. It isn't here yet. It has not been successful. You're starting to start hearing more about DNA editing, which is actually turning out to be very, very interesting, but not yet ready for prime time. But we're also looking at editing of messenger RNA to try to correct that, already in phase 1 trials. Learning to read through those premature stop codons, we should have some data by the end of December. and then amplifiers to increase the efficiency of the production of protein. We want to do better with our correctors. So here's an example where Orphan with Lumacaftor is a corrector. We're currently testing another one, VX661, and we're already looking at the next generation of correctors where we can combine them to increase the effect they have on increasing the quantity of CFTR. And then in terms of potentiating their function, so much like with Ivacaftor, to increase the opening time of these channels, but also trying to prolong their presence and looking at these inhibitors of enzymes that are responsible for the turnover of these molecules. So we have a lot going on, and to put that into some perspective, I'm going to show you a number of these medications that I just mentioned and where they are in the pipeline, and note that this is not a complete list. There are drugs that are in development that I have not mentioned here, and I realize the text is small, but you'll have access to all of these. And actually our biggest challenge now is getting enough patients to participate in these trials that we can answer these questions. So we have made tremendous progress in the treatment of our patients. Survival is clearly better, but we still have a long way to go. We need new medications. These recent developments have demonstrated that we can do this. It's not a cure, but it can have a tremendous effect upon the impact of our lives of our patients, which I'll get to in my next presentation. But it also is an example of personalized medication, because we have to find the right medications for each of these individuals. And until we get that goal, though, we have to make sure that we use our current armamentarium very effectively. And so we actually use, as you'll hear about in Mary's presentation, about how we use the registry to design important comparative effectiveness trials and learn about what are best practices for the treatment of our patients. All right, I'm going to go right into the clinical benefit and to give you an idea of how we think and how we look at the data that we get and use that in the care of our patients. But we have a number of different medications that we have available to treat our patients. So this is a great thing to have. There was a time early in my career we didn't have any medications that had been proven effective. So we have a lot of choices. But remember, I showed you that slide that described all of these complications. So what I showed you on that previous slide was the medicines that we have to treat the lung problems, but we're dealing with sinus issues, GI issues, so digestion, bowel obstructions, and gastric acid supplements, and so forth, sinus disease, endocrine disease. Most of our adults will, half our adults will go on to develop diabetes. We have other issues that we're dealing with. So there's a lot of other different moving parts and a lot of different medications that we have available. But I can get up here and talk about as if CF was all the same, everybody was the same, but the truth is that everybody's different. And you got to find the right group of therapies that work for each individual patient. Here's an image of a young Irishman. Stuart Elborn gave me this picture of a patient sitting in his hospital bed with all of the medications that he is asked to do every single day. Now, some of those you're not going to recognize the names because they have different names in Ireland, but you're going to see aerosolized medications, a lot of pills, and so forth. And this doesn't even include the other therapies like airway clearance therapy that we ask our patients to do. So when we think about treating patients, we have to recognize the burden that these patients are under. And there is the burden of disease. They have their daily symptoms, their cough, their sputum production, chest pain, shortness of breath, but also the GI symptoms, the bloating, the frequent bowel habits, and so forth. Episodic complications with pulmonary exacerbations, but also the progression of disease over time, the knowledge that their life is expected to be shorter than those of their friends, and the impact it has upon their family and their social life. Talk to an adolescent, they just want to hang out with their friends. They don't want to have to live a life of therapy. But then there's the burden of treatment. We got a lot of medications, a lot of therapies, nebulization, airway clearance therapies take time. Medications, as you all well know, are expensive. They miss work, they miss school, there's complications that can occur associated with treatment. There's no drug out there that doesn't come with some sort of baggage, and we have to think about that when we treat our patients. So when we think about the goals that we have, obviously we'd like to cure our patients. That's our ultimate ambition, and we're not there yet, but we will continue to strive towards that. So mostly what we focus on is symptom relief. We want to make them feel better. We want to prevent the progression of disease. We want to modify this disease, prevent these exacerbations, and we want to do it with a high quality of life. So when we think about how we're doing in our treatment of our patients, we have several tools that we have to assess their response to therapy. Lung function, so we're constantly measuring pulmonary function with spirometry. I'm going to talk a little bit about pulmonary exacerbations. These are the episodic events with the worsening of their symptoms and signs. Quality of life, we now have instruments that measure the quality of life. And then there are other things that we can look at, like nutritional status, other symptoms like sinus discomfort, monitor their glucose control, and so forth. So I want to talk a bit about lung function, and again, I'm showing you registry data. This is looking at the entire population over time. CF is a progressive disease. They get worse over time, and so what you see looking at lung function, this is looking at spirometry, looking at FEV1 as a percent of predicted, which is one of our most useful tools, and what you see is that there is a slope to this, that as our patients are getting older, they are getting worse. But what you can see, again, is some of the success that we've had is that these are separate cohorts dating back to the 90s, and then each cohort moving upward. You can see that we've done a better job of getting them with better lung function early in life. We still haven't fixed this slope, but we're starting off at a higher level. So we focus on that, and if we really want to modify the disease, we want to change this slope, make it more flat, ideally totally flat, so that they would have normal lung function through their whole life. Pulmonary exacerbations. This is one of those things that's a little bit hard to define, but we all know it when we see it. What we mean by exacerbations, it's an acute worsening of signs and symptoms. Typically respiratory symptoms like cough, increased sputum, maybe they're coughing up blood, greater fatigue, appetite is down, maybe losing weight, and often accompanied by some objective findings like an acute drop in their lung function. These are very frequent events. If I look at the registry, I can tabulate these, and I can say, well, in 2010, we had about 20,000 events that were treated with intravenous antibiotics. But that's not all the exacerbations. If I look at other sorts of data, the number of events that we treat overall is closing in on 50,000 events a year. And actually, the CF Foundation has supported our endeavors to try to improve our treatment of exacerbations so that we can identify best practices for their treatment. Exacerbations are important because they're resource intensive. Many of these result in admissions to the hospital, IV antibiotics, missing of work, missing of school. It has a negative impact on their quality of life, and it is associated with decreased survival. We have numerous, a great deal of literature that support how bad these events are, and we want to try to prevent them. In this cartoon, I'm sort of giving you an idea of what an exacerbation might look like. So I'm looking at this signs and symptoms and lung function, where better is high and worse is down below. And there's this feeling, there's this general level of stability, and then something happens where they have this acute drop in their signs and symptoms. We intervene and things come back up to baseline. When you talk to doctors, that's what they'll tell you. I get them back to their baseline, but when you actually go look at that, they don't get back to their baseline. And when you look at registry data, looking at how often do patients get back to their previous baseline, which is noted as their best lung function in the previous 6 to 12 months, depending on where you set your goal of what you mean by recovery, if you say, I want to get you all the way back 100% to what your baseline was, that happens about 50 to 60% of the time. When you set lower thresholds, like say 90% of their baseline, well, you get there 85% of the time, but we can't accept a 10% loss in lung function. That is just not acceptable. They don't get that back. And so it could be that we have to improve our treatment of exacerbations to try to get there, but more likely is that we have to prevent these events from occurring. When we look at other features, not just lung function, but lung function is intimately related with nutritional health. And generally speaking, as lung function gets worse, so does their nutritional health. On the other hand, as their nutritional health gets worse, their lung function is worse as well. It's sort of a chicken and egg scenario. But what you can see is that in the pale dots is each of these dots is a separate center, looking at their median lung function on the y-axis and their median body mass index on the x-axis. And so if you think that a better BMI and higher lung function should push you up towards this right corner, I think what you can appreciate is moving from the pale dots to the blue dots, going from 2003 to 2013, we're doing a better job. We're shifting that curve up to the better, and that's what we want to continue to do. Let's look at how we use these endpoints in practice. So I showed you earlier Ivacaftor and the win that it had both on lung function, reducing exacerbations, improving quality of life, and actually increasing nutritional status, looking at weight in these patients. So that was actually tremendous, but not every drug is a home run like that. So how do we think of these drugs and the value they provide for our patients? So let's go back to one of our early developments, which was inhaled antibiotics. Inhaled tobramycin was the first inhaled antibiotic approved for use in our patients. This was back in the 1990s, and what you see is the placebo group was declining during this time, and the treated group, month on, month off, month on, month off, a cyclic method of treatment, lung function improved considerably, and then dropped a little bit when they're off drug and so forth. That was great. That was a big improvement. But when you look at more recent drug development, this is again looking at that same study, looking at it reduced exacerbations in that same study. This is the patients on drug compared to placebo. So there were fewer exacerbations and they were delayed in time. But more recent drug development, this is looking at the development of inhaled aztreonam, comparing it in the blue to inhaled tobramycin in the red. There's a few points you can see from this slide. The first one is the temptation is to believe that tobramycin isn't working anymore. But that would be false, because in order to know that, you'd have to study it compared to a withdrawal study, take away that. And I'm not going to show you those data, but we've done an analysis to demonstrate that even though it seems flat here, it is still working, that these patients who don't get drug are actually worse. The second thing I want you to see is that the aztreonam doesn't have that same robust response I showed you just 2 slides ago in terms of how good tobramycin went. Part of that is because those TOBI studies were done principally in adolescent patients. And this was done in patients who are mainly in their upper 20s. So they're older with more established disease. The third thing I want you to see is that there is this slope to this, that you get this attenuated response with the inhaled antibiotics. That is typical of every antibiotic we've looked at over time. Again, it does not mean it's not working or working as well. It just isn't perfect in terms of solving that. More recently, with the approval of Orkambi, we showed you the Ivacaftor data, which showed a big 12% improvement in lung function, and the Orkambi data was something less robust. So it was like 2 to 4% improvement in lung function, which caused some people to think, well, is that really worth it? Is that enough? And we've had many conversations with the FDA, what is the magnitude of effect? But we have to think of it in different ways. So one, yes, this is clinically and statistically significant. In the open label study afterwards, where patients who are on placebo were allowed to go on to drug, this is encouraging to see that you get a consistent response. And although there is some slope to this line, as if they're having some attenuation in the response, keep in mind that way out here, more than a year after the whole study, their lung function is better than when they started. All right? That alone is a victory. More important is when you look at the data that we have now, that we've been able to have the drug and monitor patients for longer periods of time. And the way that we do this is compare patients who have been on Orkambi to those who have not. We can pull this out of the registry. And what you see is that you get that initial bump for the patients who are on Orkambi, but more important is to look at the rate of decline of lung function. And what you see is that these numbers start to separate considerably, so it's slowing the rate of decline of lung function. Again, it might seem small, but think of this like you do compound interest, that you can start having these lines separate. What does that do over 5, 10, 15 years? That is a clinically meaningful response, and that's something that we're very excited about. Mike Constant presented these at the Rare Diseases meeting, and it's going to be presented again more robustly at our upcoming meeting in the next couple of weeks. Also, in the original study with Orkambi, the time to first pulmonary exacerbation was delayed. So there were fewer exacerbations, and the time to the next one was delayed. But now that we have longer-term data, this is very encouraging. So in the initial study, there was a 40% reduction in the rate of exacerbations overall. And when you look at these patients in the subsequent year, whether they converted from placebo to drug or stayed on drug, that reduction in exacerbations persisted. And we know very well that the history of exacerbations is the strongest predictor of exacerbations. So reducing those exacerbations over time is a sustained benefit in these patients. So key takeaways from this, again, I think we've made real progress in the treatment of patients, but we have to recognize that these patients come not just at great cost, but at considerable burden to the patients. Our new therapies offer tremendous hope. We are not satisfied that this is the best in the end. We need to do better. And introducing these therapies and using them to individuals to maximize benefit while limiting the burden is our goal. We're trying to find for each patient what is the best group of therapies.
Thanks, Patrick. Thanks, Patrick.